So endometrial cancer is currently diagnosed by a pathologist, and pathologists are doctors that specialise in looking under the microscope at tissue samples and assigning a diagnosis. So pathologists would get an endometrial cancer biopsy or a hysterectomy specimen and look under the microscope, and they would assign both a tumour grade and a histotype. And in endometrial cancer, this has been shown to be very subjective. So that means you could give the same endometrial cancer biopsy to 3 different pathologists who could potentially call or diagnose that endometrial cancer in 3 different ways.
And this other, of course, consequence of having inappropriately categorized tumors is that you group tumors together that can actually be very, very different. And so trying to interpret what treatments work best in different tumors is very challenging, and it's slowed us down in our progress. So we're in a really exciting new era. I think endometrial cancer, despite being so common, has not had the attention it deserves. With this framework that molecular classification provides, we can now group biologically similar tumors together, finally looking at apples with apples. So we're going to be able to, I hope, make leaps and bounds, figuring out what treatments work better for which patients.
So treatment guidelines are now changing around the world to use molecular classification to guide treatment decisions in endometrial cancer. So for patients with polymutant endometrial cancer, we know these are the patients who have excellent outcomes. And many of these patients now have the opportunity for de-escalation of therapy, which means they have surgery only. And many of these patients in the past would have been recommended to have additional treatment after surgery, such as radiation, and sometimes radiation and chemotherapy. And obviously there's the chance of side effects from these treatments, which were likely were not actually needed because these patients have such excellent outcomes. For patients identified as having mismatch repair deficient endometrial cancer, or the MMRD subtype, these patients are at increased risk of having Lynch syndrome, which is a hereditary cancer syndrome. So it's really important that these patients are now that they're identified, that they either have additional testing performed on their tumour, or they're referred to a hereditary cancer program where they can undergo testing for Lynch syndrome. Because obviously if this is identified, this has very important implications for both the patient but also the patient's family members as well. We also know from many studies now that patients with mismatch repair, or the MMRD type of endometrial cancer, respond really well to immunotherapy. So this is a really important targeted drug option for patients with MMRD endometrial cancer who may need additional treatment after surgery. Then there's patients with NSMP or P53 wild type endometrial cancer. We know many of these cancers are hormone receptor positive, so have either estrogen and or progesterone receptor positive tumours, and there are studies that are opening up that are looking at using hormonal treatment for patients after surgery for NSMP endometrial cancer. And lastly, P53 abnormal endometrial cancer, we know that from recent studies, these are the patients with endometrial cancer who actually have the most benefit from chemotherapy after surgery. So chemotherapy is a really important treatment aspect for a patient with P53 abnormal endometrial cancer. There are also some exciting targeted therapy drug options that are going to be explored in this subtype as well. So one example is PARP inhibitors, which is actually a type of treatment used in certain types of ovarian cancer. So this is going to be studied in the P53 abnormal subtype.
In the beginning, the only reason I even had any kind of inkling that something was wrong, I had no discomfort or pain or any other symptoms except I had some bleeding.
We were able to obtain her results after surgical staging, and that redirected her to having no additional therapy. And we have other patients like that as well, where they might have been, by treatment standards even 5 months ago, directed to 3 cycles of chemotherapy and to radiation, and instead with a polymutation, even though there's under the microscope type features that look to be unfavorable, we know these women do exquisitely well. And we were able to say look, we don't think we have any evidence to say that treatment makes a difference in the outcome, and we'd offer you close surveillance.
Further testing was then done on the tumor, and it was determined that there was in fact a genetic predisposition to those two types of cancers, which ended up sending the biopsy through for genetic testing, which then provided information on the fact that I had Lynch syndrome. It's likely probably that my mother also had it. She died of pancreatic cancer at the age of 60, and her cousin at around the same age died of colon cancer. So it looks like it was probably a familial issue that wouldn't have been recognized in my mother or in my mom's cousin because that testing wasn't done. Obviously, with that Lynch diagnosis, it means that I am at risk now for pancreatic cancer and colon cancer, 2 of the 4 that I have not had. So it has enabled me to go through annual testing for both of those with MRIs, colonoscopies, endoscopic ultrasounds, all of that on alternating years. And as a result, I know that at least if something were to come about, then it would be well tracked and I would know in advance.
So the PROMIS molecular classification now provides a very important framework for developing clinical trials in endometrial cancer, where we can now finally assess the effectiveness of various treatment options within biologically similar tumours.
What can you do today? If you have been told that you have endometrial cancer, you should ask your oncologist for PROMIS molecular testing to be performed on your tumor. This can be done on your biopsy or your hysterectomy. You should also ask your oncologist to explain how your PROMIS molecular testing results will change your endometrial cancer treatment journey. Specifically, do you need to be referred to the hereditary cancer program for genetic testing? Are there specific therapies that should be considered? Are there clinical trials you are eligible for?